before we go into some more details about the CAR T cells data in specific, I think one question might come up. We have 3 BCMA targeting agents, the ADC, we have the BiTEs, and we have the CAR T cells. And what's not so clear is how do we would think of using them? Do you think one given patient would be better served with one drug versus another drug? Do we feel, and I do feel that we should be able to use more than one of them, right, even though they target the same? What is your view? And it's not a settled issue.
Exactly. So the biggest challenge to CAR T cells is that there is a production time, unless we get third-party allogenic CAR T cells, which is also very excitingly in development. So they're not off the shelf, so to speak. So for a person who needs treatment today or tomorrow or in the next week, CAR T option may not be available, even in clinical trials right now. So for those patients, something off the shelf such as the ADC or belantamab or something off the shelf such as a T-cell engager might prove the answer. And the other thing is the ability to tolerate. Many centers do CAR T cells very similar to how they do transplant. And although patients older than the transplant age are being given CAR T cells now, we have a cellular therapy, need to have cellular therapy expertise in the center to use it. So it may not become universally available across all the centers that treat myeloma in the country, especially in community centers and smaller towns. So that patients may have to travel to get CAR T cells. And then the period of toxicity can extend up to a month, sometimes even a little bit longer, and that again becomes an issue. On the other hand, most CAR T cells are designed with a one and done approach. And we are, at this point at least, not reporting on studies that give something after the CAR T cell. So that might give a time of without disease and without additional treatment, which may be fantastic for our patients.
But I think there is almost beginning of data where patients could be treated with BCMA CAR T and then have received ADC after that.
Absolutely.
And responded. Yes. So those two, I think, in my mind, are quite easy. What I'm not so sure about is that can a patient who got CAR T cells
then
get T-cell engager?
Yeah.
Or if they got T-cell engager, then they get CAR T cell. In theory, it's possible.
Yeah.
Practically, we do not know. Those kind of approaches have not been done. I'm aware of one, at least, publication where patient got CAR T cell, relapse, and was treated with the T-cell, the ADC, BCMA ADC, and had responded. Yes. And so there is anecdotal results, but I think we need to get more data on all this combination.
Yeah.
And then, as you said, time may be a factor. So if a very fast progressing patient, we may not have time for one, then we can use off-the-shelf something. And there's a lot more to learn from the CAR T cells, various varieties of it.